Okay, lots of people are beginning to come in, so I'll begin by welcoming everybody this afternoon. It will take a couple of minutes for obviously people to finally come in and join, but I just want to welcome everyone to our session this afternoon, which is learning from vulnerable sector involvement in neighbourhood working, with a particular focus on neighbourhood working around sort of children and young people. In a few moments, I'm going to hand over to some of my colleagues who've been part of this network and this sort of program. I'll introduce them just before I start, but just want to move on by starting with a few housekeeping items. So if we could move on to the housekeeping slide, that would be brilliant. Thanks very much. If people could leave their microphones on mute, that would be brilliant. We had about 100 people book into the session. We're up to about half of that now already. So there is going to be a lot of people on the group. So if you could leave your microphones off, that would be great. It's up to you whether you want to leave your cameras on or cameras off. Please feel free to use the chat function. With this many people, it's going to be very hard for us to actually have actual questions from people live, but I will be helping to, along with others, just to keep an eye on the chat function. So any questions that are posed, I'll try and gather them, and we're going to look at those at the end of the session. We are recording this session, and so the recording and slides and materials will be shared. If people have any AI, transcription or whatever, if they could not sort of activate that, I think Lynn from Von Sector Northwest is using, you know, her powers of veto to eject any AI tools, just so we don't have lots of other versions. And just to say to people, if obviously you wanted to participate, you wanted to share in the chat, you know, please be respectful, please be open to a variety of views and opinions. So I'll move over to a quick look at the agenda. Well, as said, my name's Dave Packwood. I'm the coordinator of the Children and Young People's Vulnerable Sector Network for Vulnerable Sector Northwest, and I've been working with the colleagues on the call for some of them about the 3 years of the network, and some of my colleagues in local authorities a little bit shorter. But in particular, what we want to look at today is the learning from the Beyond programme of neighbourhood pilots that Liz is going to talk about in a few moments. And we've got colleagues from both Cheshire West and also Sefton who are going to be outlining that. I don't know if that's me echoing or whether it's somebody else. If people have got their microphones on, if they could mute them, that would be brilliant. I'll mute mine after the end of this. And then at the end of the session, just probably after 2 o'clock, we're going to do a bit of a Q&A. I've summarised some things I think have already come out of the presentations that I've had a look at, and I'll be gathering just some thoughts and further points at the end of the session, and a chance just for the people that presented to answer any questions that have been raised. So without any further ado, I'm going to hand over to Liz Crabtree, who's the programme director of the Beyond programme, and who I've had the pleasure of working with for about the last 2.5 to 3 years. So as I said, I'm going to mute myself and hand over to you, Liz. All over to you.
Good afternoon, everybody, and thank you so much for joining this afternoon. It's great to get everybody engaged in what I think is a seismic shift in how we're going to be delivering care across the system, and that isn't just in healthcare, but that's across social care, our third sector colleagues. So yeah, lots to be thinking about today. So thank you. Oh, sorry, I haven't got a charger, whoever requested. If you could go on mute, that'd be lovely. So I'm Liz Crabtree. I am the programme director for Beyond, which for those of you who don't know is the Cheshire and Merseyside Children and Young People's Transformation Programme. And we've been a programme of work that's been established now for about 5 years, looking at how can we improve outcomes for children and young people, but primarily looking at how do we shift that care left? How do we think about early intervention and prevention? And how do we think about addressing the wider determinants of health and the health inequalities landscape? And neighbourhood health is absolutely at the centre of how we will be doing this in the coming years. So thank you very much. Would you like to go to the next slide, please? If you click through just till the end of this slide, because otherwise it's going to take a while to get through. Thank you very much. The joy of bits that come up as you go. So I think it's really important to look at the national direction so far, but I'm really mindful that this is just the national health direction. And actually, this is aligned with a direction of travel across our whole system that is looking about how do we redefine how we deliver support for children and young people. We know that we've got the SEND paper that's changing. With the experts at hand about how do we make sure children don't have to go through hoops to access the support they need. We've got Family First, we've got family hubs, we've got youth hubs, and we've also got the National Health Service direction of travel. So actually, all of our policy directives are about how do we take what has historically been expert care at the far end of the system and bring that forward so that families access better support much more quickly. And that meets what families tell us about. They don't want to tell their story millions of times. They don't want to have to tell it to every person that they speak to. They don't want to get lost in the sharing of information between systems. So from a health perspective, we had our guidance in January 2025 that started to think about how do we, at the core of our business, look at population health, how do we look at community delivery and neighbourhood multidisciplinary teams. So it started to be embedded in the policy direction probably nearly 18 months ago now. So we started to think about that. And what I would say for anybody working in this field is that it's not rocket science, it's not new particularly, but it's come back into how do we coordinate our services. So I've been in the health service since the late 90s, and I started my life in a Sure Start centre and in a social work office, and I used to go into special schools with educational psychologists, speech and language therapists, with my primary care colleagues, and we used to think collectively. So it is about how do we reimagine that in a way that's fit for the future and think about things differently. And I know there's pockets of good practice out there, but from a policy directive, it came in January. And then alongside that, and it was really good to see there was a focus on children and young people. So historically, there's been quite a lot of national directives, and children and young people have been a bit of an afterthought. But actually, right at the very beginning, in the foundations of thinking, we had some guidance on how do we do this for children and young people. It aligns with Fit for the Future, the 10-year health plan, which looks at hospital to community, analog to digital, and sickness to prevention. It looks at us not looking at sickness as a model, but how do we maintain children and young people as healthy young people who have the best start in life. It's absolutely in the medium-term planning guidance, and for Cheshire and Merseyside, it's been writ large through all of our planning and our joint forward planning. And we've got the neighbourhood health framework that's come out more recently, but within that, children and young people are seen as a population cohort who absolutely we need to be getting this right for. So it's been really, really good to see children and young people within this. We have two pioneer place areas in Cheshire and Merseyside. We had hoped that children and young people would be part of that pioneer cohort. It hasn't been, but more recently we've had clear direction from NHS regional team that they expect children and young people to be one of our priority cohorts going forward. So absolutely, we are at the beginning of getting some really exciting interventions underway. So can I go to the next slide, please? So what underpins neighbourhood health? So population health intelligence. So how do we use what we know? We have in Cheshire and Merseyside CIPHER, which is a brilliant, don't ask me what the acronym stands for, I'll find it and put it in the chat at some point. It's a brilliant way of looking at our population health data, and we can break down our children's outcomes at place level, community level, ward level, which gives us a real support about how we target our most vulnerable cohorts of people and children and young people. And we can look at child poverty measures, we can look at persistent school absence, we can look at the children who are turning up at our A&Es and into our urgent care, and how can we think differently about how best to support them, with a real focus, as I've said earlier, on health inequalities around the core 20 population, so our 20% most deprived populations, and also the children and young people who we know have worst outcomes. So that will include children like our children with SEND needs, our children who are looked after, who have neurodiversity, mental health needs, refugee, asylum seeking families. So just making sure that we're looking at all of our subpopulations and we're not losing them in our thinking. How do we improve access? We've talked about historically hard to reach communities, but actually we as services are hard to reach, it's not them. So how do we rethink our strategies so that we are easier to access for the communities that need us most in that prevention and early help lens? Next slide, please. So NHS England has looked at some of the key areas where we might be able to do some of this work. One of the things that I think is really interesting in that key statistic box is that 5 million children attend emergency departments every year, but 3/4 of those are discharged home and not admitted to hospital, which means there must have been a better route for them accessing support. And it's probably that they have struggled to know where to seek support, that they haven't had access to the right level of support, and that kind of they've ended up in an A&E department when actually we could have done things better earlier, and that children and that families say they feel overwhelmed, they don't know where to go, they struggle with timely access, and that our services are siloed and hard to access, and so we need to do things differently. So NHS England have looked at a couple of models. Mando Watson in London at Imperial has been looking at how they do this. If you go to the next slide, please. And their model is, I think this is quite a health-based model at its heart. So it's looking at tertiary care specialists, so paediatricians working into primary care, secondary care, and supporting children and young people to be kept on a pathway that doesn't require them coming in. But actually it's shown absolutely brilliant outcomes, real reduction in attendances at tertiary care services. So if you go to the next slide, it'll talk about the impact. So they've when they did their evaluation, they did a service impact over 12 months and saw massive reduction in hospital appointments, shift to more GP primary care delivery, fewer specialist referrals, reductions in A&E admissions. But one of the things I'm always really mindful about is actually we can't just shift the care to our primary care colleagues. We need to be thinking collectively about how we hold that together, because primary care is already under a huge amount of pressure. So how do we make sure that that efficiency is felt through the whole service? Because what you will find is that if children get the right support, they will also be attending primary care less, and that patients were saying it was a much better model of delivery for them, and it was also resulting in professional understanding increasing and skill increasing through that kind of multidisciplinary discussion, that sharing expertise. So if we go to the next slide. We've also been really privileged to have Rizwan Rafi from Solihull come to talk to us in Cheshire and Merseyside at the work. And I know Dave was on one of our meetings with Rizwan and said it was one of the most inspiring teaching sessions he'd ever been to. And I think that's true. And I think for me, what's absolutely brilliant about what they do in Solihull is around that third sector connectivity. So how do we make sure that children, young people, families are accessing the support they need, but with an absolute core of that being able to deliver at a community and place basis where our third sector colleagues know their populations so well and can be so responsive to needs. So a huge amount of work gone on in Solihull. If you go to the next slide. And they also saw a 25% reduction in CAMS, 27% reduction in community paediatrics referrals, and an increase, absolute vibrancy of a third sector offer that was much better able to meet the needs of the population that they served. And one of the things I'm always struck by when I speak to young people who have accessed CAMHS because I used to be a CAMHS clinician, they would much rather have been able to access a more flexible offer closer to home that wasn't the 50-minute hour that I could offer them in a CAMHS clinic. There were some young people who absolutely needed that, but some young people absolutely drifted to that when they could have had a better offer elsewhere. So if we go to our approach in Cheshire and Merseyside, so Beyond has been asked by Cheshire and Merseyside ICB to convene the system around children's neighbourhoods for our region. There is a lot of work going on in the adult sphere, and we are convening in our children's sphere. And actually underpinning our approach is to establish consistency and equity so that it doesn't matter which postcode you live in, that you will get access to the right support, that we're able to scale and sustain any approaches that we deliver, that we have an integrated workforce that isn't siloed, that isn't kind of in our own little parts, that absolutely wraps around our families and provides them the support they need, that's underpinned by digital and data. I think we sometimes get caught up in some of the difficulties around data sharing agreements, etc., but we need to be able to get underneath that, because actually we need to all understand how best to support our communities, and we need to strongly govern what we're going to do. So we have a MDT focus group that is all our colleagues from our 9 places, and we meet and we share and we learn, and we make sure that we're continuing to push on our development. We're driving standardisation, but recognising that you absolutely have to have that local flexibility. And one of the key things for me is that we are aligning across our system around all the changes. So it's linked to Best Start for Life. We're working with our family hubs. It's linked with Families First. And we have a commitment from all of our 9 places that we will have 1 MDT per quarter in place by Q1, which is this quarter, and that we will be driving to get much better coverage as we move forward this year. Next slide, please. This is kind of the nuts and bolts of the governance, just so you know that it's well overseen. We report into the ICB, All Age Neighbourhood Group, but we also report into NHS England because they're keen to make sure that we're sharing good practice. Next slide, please. So this is how we've run it. So we were fortunate enough to be able to carve out a bit of money in last year's budget, and we were able to use some of that funding to support and pump Prime. I've just noticed somebody say lots of acronyms. Can we provide a glossary? I will do, I promise. Sorry about that. You get used to the language and you forget that probably some of it's is not well known, and we'll sort that out. So we ran our EOI from September 2025. And 8 of our 9 places submitted bids. Unfortunately, we couldn't provide for everybody, so we had an evaluation panel. Dave ably assisted us from a third sector delivery arm, and we identified 6 places who we could provide funding for, but an enhanced offer for the 3 who didn't get funding so that we could continue support as they move forward. And we are monitoring delivery through key lines of inquiry, which has been ongoing. We've had our first set in already, and a next set is due soon. And we had a fabulous event at the Florey at the end of March where we brought together our national colleagues, our pioneer status coaches. Dave presented, Nasima from the Directors of Children's Social Care Forum came. So we were able to look at that whole system approach and how we could take this forward. So where are we going next? Next slide, please. We're auditing what's going on, because our 9 MDTs are not everything that's happening. We know that people are taking that forward on a local level as well. We're continuing to monitor delivery and get those MDTs set up. But actually, if you look at the guidance from NHS England and from social care, there is a requirement for us to push further with this faster over the next year. And I think there's a commitment from NHS England that by 2029, all children will be able to access a neighbourhood MDT if they need it. So we've really got to get under the skin of this and move it forward. So next slide, please. This is a bit of a visual about our areas and the levels of support they're offering for their children and young people. We'll circulate the pack, so you don't need to look at this in any great detail today, but some colleagues are looking at respiratory care. How do we support our young people who have asthma and respiratory difficulties. We know that for those young people, they'll be heading into tertiary care to have their asthma managed, but in all likelihood, they're living in housing that isn't not acceptable and has mold. They will be struggling with getting a good diet. They will be struggling with getting good exercise. They will be living in neighbourhoods where there's an awful lot of air pollution. And so actually, it's not just about getting the right medication, it's about everybody wrapping around and maximising income, supporting housing, etc. Some of our colleagues are looking at neurodiversity because we know we have thousands of children waiting over 52 weeks waits for assessments, and they need something now rather than waiting. We have people looking at those young people who bounce between the system with complex needs. So lots of really, really interesting work going on, and we're going to evaluate and bring forward the learning from that as we go. Next slide, please. That was our neighbourhood event. So a lovely picture of us all there. It was a sunny afternoon in South Liverpool, and really good feedback from that. So if we go to the next slide and then the one after, please. Okay. So this is the opportunities that we've identified and the challenges. So in green are our opportunities. We've got one of the great things is that access to population health. Thinking of children and young people as a population cohort rather than a subsection of kind of adults. But we do know that there are challenges where so many different systems are used, they don't always talk to each other, that some of our, I think kind of my conversations with Dave, we give money to our third sector colleagues, but we don't give enough money to allow them to monitor through data management systems that link to our own in health. And our social care systems and our health systems don't always interact properly. So I think we've got to work on that. There's real opportunity with the single child identifier, which will help us get kind of data sets that talk to each other, but we need to work that through. There's a huge interest and partnership in this. It's been lovely to see the EOIs, the expressions of interest that showed real strong partnership working with our third sectors. How can we do things differently? Lots of multi-agency work in place, but we do need to think about how do we create the capacity in the system while we're double running before we free capacity up elsewhere. So lots of challenges still ahead, but real opportunities. We've got lots of knowledge, lots of skill, but we need to think about how do we identify capacity. But there's a real risk around the duplication or the parallel running of social care and policy and health policy and education policy, and how do we knit them together in a real sweet spot to enable delivery. And that links to that too many reforms at once, and we need to learn and evaluate as we move forward. So there is in the pack, and I'm not going to go through this, we'll circulate it. There's information on all of our places and the work that they're doing and the impact that they're having. But that'll probably be where I end for now. And I have the real privilege of handing over to a couple of colleagues who are going to talk about how this is working in action, and how our third sector and health are delivering in partnership in Cheshire West. So I will introduce Bev Morgan and Heather Cattrall, who will take the lead from here. Thank you very much.
Thanks. Yeah, thanks, Liz.
Appreciate that introduction. So Bev and I are going to do a bit of a double act and represent the work that we're developing in Cheshire West around our children and young people's neighbourhood approach for the focus around health and wellbeing. Next slide, please. So first of all, I won't dwell on this too much in terms of the national policy. Liz has provided a really in-depth overview of kind of the direction that we've had from the national policy from a health perspective and wider organisations. So this is just the first part, capturing that bit. In terms of what the neighbourhood approach is from a Cheshire West perspective, we were successful in receiving the expression of interest and the seed funding through work with the voluntary sector colleagues and our wider partners. We'd already started to establish what the neighbourhood approach was required from a Cheshire West perspective locally, and what that meant in terms of the neighbourhood guidelines that we'd received in towards the end of 2025. The direction that we took in terms of the expression of interest was to outline a model that really described how the neighbourhood model would be led by our primary care networks and have a real primary care focus, but also importantly had the voluntary sector at the heart of it as well, recognising the important work and the links with the families, and that relationship that the voluntary sector can really have a massive value in terms of incorporating that with our joint model. So the community approach that we took with the seed funding was to work with 2 of our primary care networks within the Chester footprint for Cheshire West, and this was based on our population health data and looking at our deprivation indices to give us that perspective, along with our children's education attendance records with the local authority as well. So within the guidance, it indicates that the population size for a neighbourhood should be around 30,000 to 50,000 for a group of GP practices working together. For our 2 PCNs, we've got Chester South and Chester Central. In total, there's 10 GP practices within those 2 PCNs, and I think there's, from the GP data, there's approximately 18,000 children and young people that are registered with those practices and within those 2 PCNs footprint. That equates to about 20% of the population size for the PCNs. We are focusing looking at the communities, but also we've taken the direction that to make it a true neighbourhood approach and a partnership, that we move away from calling it an MDT, a multidisciplinary team. We felt that on reflection from our engagements initially, that the MDT actually felt quite clinical. And for our wider partners, we wanted to make sure that this was a true reflection on actually it's a multi-agency approach. It's a multi-agency coordination of bringing together the services that we've got at a neighbourhood level to really support the families. So not just the children and young people, they're at the heart of it, but it's the wider family around the child and the children within that family dynamics, to be able to support them in the best way possible. So we have we've looked at what fragmented services we've got across the system, and actually how do we look to improve that. And as Liz mentioned, it's really focusing on the prevention and early help that we can identify. So we've worked through a criteria. So considering the more laterally, the SEND reform, the white paper, and also the Families First programme and the family hubs. So we've identified the model so that it's about that really true early intervention, that level that is way before kind of social care, safeguarding, anything that's further advanced than that level. Okay, thank you. Next slide, please. So just reflecting here in terms of the PCN as the anchor, as it says in the national guidance, that it should be primary care led and the primary care networks. So we have, we know that the GPs and the primary care networks have that long-standing relationship with local families, but also recognising the voluntary sector relationship. And actually, we've learned through developing this project that the value that the voluntary sector can actually shed a lot more insight into the family dynamics and actually what the true root causes of some of the problems that families face in regards to what maybe the GP sees in a 10-minute consultation, and actually what they are very focused, quite rightly, on resolving the issue that comes to hand. And it's about that wider kind of information and detail. So an important role around the GPs and the primary care network. The PCNs hold a lot of population health data, and we've proactively identifying families who've got complex and unmet needs through our population health data, our complex household data, and our high intensity users, as well as that softer intelligence as well around something not feeling quite right with a family, and some things identifying that could do with that additional support. So our over on the right of the slide, you've just identified the PCN roles within our multi-agency coordination model, so our MAC model. So we have the GPs actually chairing the MAC meetings, so they're really that facilitator around the discussions and ensuring the safeguarding elements, if there are anything that is rising from the information being shared from different partners, and building that bigger picture, that we actually address it there and then, and it's supported through the appropriate safeguarding and governance routes. We've got the PCN admin and management roles. So the GP chair, the PC admin manager roles, they are actually funded from that seed, from the seed funding. And their role is to manage the referrals that come in, do that quality checks, address the agenda, log the decisions, and we have a tracker for the journey of the family and the child throughout the process, which importantly won't be a fixed period. We recognise that some families' issues will need support for a longer period, and it could be anything up to 9 months, 12 months before actually we see, or we get that feedback on actually a difference being made. So they also importantly that we get that GP reflects the clinical insight and oversight to the programme. Next slide, please. So moving on, so the voluntary sector. So I mentioned the funding identified to support the roles within the PCN. But importantly, we've also identified, and the majority of the funding is actually going around the core partner, the voluntary sector, at the centre of this. So the voluntary sector is a dedicated role that sits at the heart of the MAC. It's not funding to deliver a service around the families, but it's a role, a family link role, that is around reaching out, making that contact. So once we've got the referral and the consent, which is sought from the referrer, so primarily around the GP practices and then fed into the PCNs. The voluntary sector role, the family link, will then reach out to the families, provide more soft intelligence, more information around what the MAC is, how that we can support them. And then they provide that contact and build that development around the whole family with engagement to be able to feed in and represent the family's voice and their lived priorities within the MAC meeting itself. I won't go too much more into the details there, but what we essentially one is that the families don't feel that the MAC happens to them, that they are central to every decision, and it's fed back. And if we move on to the next slide, Bev's going to be able to describe more about the role from Koala's perspective.
Yeah, thanks, Heather. As Heather's just explained, sort of, they had the voluntary sector at the heart of their ideas at Cheshire West when they first put their expression of interest in. And working with Cheshire West Voluntary Action, they put an process out through to the voluntary sector across Cheshire West for organisations to apply. We did apply, and we're the organisation that was successful. We're really excited to be part of this pilot. It's a new way of working, and we're at the beginning of that journey. But I just want to give you a little bit of a background about my organisation. So, as Heather said, I'm Bev. I'm the CEO at Koala North West, and we've been supporting families for 26 years. What we do is rooted in family support and early help. We've got we work in the two areas that have been chosen by Cheshire West for this pilot. We've been working for a while, and have got good relationships with not just organisations in the area, but a trusted relationship with families and the community. And we do work across with health, with local authority, and across all the community. And we do specialise. We do have a real sort of experience of engagement with families who find systems hard to navigate. And we really are an experienced partner, multi-agency and integrated working. So that is at the heart. So, but also it's important to note, as Heather said, this funding that we received through this pilot is not to deliver family support. It's not delivery funding. It's a very different role. So next slide, please. So our role is the coordination role. So it's about bringing families' lives and lived reality into decision making, and even just to sort of those very early initiation of meetings with the GPs and the other health professionals and others around the table, before we even start talking about families. Sean, who's our coordinator for this role, has been able to sort of share and put things from the family's point of view that maybe some of the GPs and others in the room hadn't thought about. Our role is about translating what particularly the health professionals around the table are asking and saying, and translating that for families in a really simple way so it's not quite so intimidating maybe sometimes. Supporting them to stay engaged between the meetings as well. So I'm going to come on a bit more about that. And reducing that disengagement, hopefully, so families aren't missing so many appointments and not disengaging with their health services that their children should be accessing. And then our role will very much be about feeding that learning back into that partnership, sort of every meeting, Sean going back in and talking about what's been going on and what we've learned from the experience and what we're learning from families. Okay, next slide, please. So as I've said, we have recruited a part-time. Sean was a member of staff for us already, a very experienced family support coordinator. So we've given her some additional hours to work on this, dedicated to this work. And she is the named link for families involved in the MAC. So she goes to monthly meetings, or leading up to this, a few more the early days, sort of lots of the preparation meetings. And she is the person who phoned the family, explain the process, ask if they're happy to be part of that, and get their consent. It is all with consent. So if a family chooses not to be part of this process, that's completely up to them. And then supporting them through that process and understanding of what they're agreeing to, and feeding back from the MAC meetings to the families anything that's been agreed and what organisations have said they're going to do. So our role is very much about navigation and signposting. It's not about delivering family support. It's not about duplicating existing services. It's also about, we know the organisations in the area. So Sean's got good relationships with the other voluntary community organisations in the area. So if something comes up that a family is looking for support in, that there isn't normally an organisation that we don't know that we can't signpost to. So it's all about feeding that learning and gaps and outcomes back into the MAC and monitor and review. So like I say, it's very early days for us, but this is the intention. Okay, next slide. So Do you want to have it? Yeah.
Thanks, Bev. So just to outline here the key principles of how we work together in terms of bringing the background information for the MAC. As Bev said, we did a dry run in March where we had non-patient identifiable information and referral forms that came into our initial virtual MAC meeting. It identified the opportunities for our partners across all sectors in terms of identifying the families, but it also identified the real importance around being able to get the consent and being able to have that patient identifiable information that we can then coordinate the real background detail as to what's happening for that family. So the family are at the centre, and every decision reflects on the family's own priorities and goals. We feel this is fundamental to what we can achieve with the MAC and the approach we want to take. And Sian's role from representing the voluntary sector is integral to making sure we get that right and keeping that the focus. Sian also is that representative from the voluntary sector. As Bev said, she knows the colleagues and the voluntary sector services that are available, so she will be able to identify and feedback, and as part of the overall plan that's developed within the MAC, be able to reach out to our voluntary providers to be able to identify where we think that there's an opportunity for additional support for families. The information sharing with consent, so we've gone through a explicit consent approach. This has not been without some hurdles and complications, which has delayed us a little bit. And on one hand, it was reassuring when we had the Beyond Cheshire and Mersey event to hear that other colleagues have, and it's a national sort of barrier that we're trying to overcome, but we have found a way around that to be able to move forward, and we are in the process where we're finalising the consent form on a digital basis so that families will receive that from their referrer. So if it's from a GP practice, it'll be through a link through AccuRx, so that the family don't have to be sat right there with the GP or with the practice, but they can have contact through their the organisation identifying them as a referrer, and then they'll be able to provide the consent on a digital form, and that will be submitted back into to our team to then be able to signal for Sian to be able to make that reach out and make that contact.
Heather, sorry,
yeah.
Heather, do you mind if I just come in there? I
Yeah,
think
sure.
that the whole process of sort of joined up working and multi-agency working across with voluntary sector, with health partners, one of the biggest barriers is that we don't have the same systems. And I think it's a national issue, isn't it? That if nationally, if the NHS want us working closely with the NHS, we don't have the same access to families' data. And rightly so, we don't need to have the same access, but it is a barrier in the sense that I think sort of the GPs and everybody, all the health professionals are on the same systems, and we can't have voluntary sector going into these meetings without not having the same information about the families that are going to be discussed. So I just wanted to say that, Heather.
Thanks, Beth. No, that's really important. And one of the ways that we are approaching this is actually to set up a secure MS Teams channel, so that it's restricted in terms of who's involved in that MAC as to who has access to that information. But that's been signed off as an approach that we can test through this pilot. So in terms of our identifying the responsibilities and the development of the plan through the MAC, we've agreed that named ownership is really important. One of the things that has been flagged is that predominantly some of the issues we know are going to be around children and young people or families that are already on waiting lists. So it is actually identifying kind of where we've got the opportunities to maybe flag that risk stratification within referrals into a service, and also actually how to support families with that kind of the journey they're on, and whether there's alternatives within the community that they can access to support them while they're waiting for their appointments, and be that advocate for them. Also, the early escalation is really important, that we make sure we've got that timely communication that protects the outcomes for families. For example, we mentioned about the safeguard and making sure that that's raised as early as possible, and other elements so that we can flag. The continuous improvement, so the learning is going to be captured through the MAT through a tracker process, and then also we're doing an evaluation on a quarterly basis to look at the opportunities that we've learned through the monthly multi-agency meetings, and are the things that we need to kind of pivot and develop and take in a different direction as we go through this the pilot itself. The pilot is the funding supports us to do the pilot from we initiated it in March, and it'll run to December. Next slide, please. Okay, so what the pilot is and what it isn't, I think this is really important to flag. So what it is, some of the things Bev and I have described to you, but importantly what it's not. So the funding isn't for those, it's not for additional services to delivery right now. We hope it will be in the future, that we'll be able to get that additional funding to support what we know as gaps within our community provision. It's not an expansion of those existing services. We're not changing or replacing any existing structures or pathways, but we're learning how we can kind of really integrate them and develop them to work closer together. It's not a meeting without purpose. Everybody will have an element to it and be brought into it on a case-by-case basis. We're having around 4 referrals per MAC meeting. We're anticipating that will grow and develop when we move to focusing and incorporating the school attendance opportunities as well to be referred in, as well as wider partners, which is really exciting that our wider partners, for example, our children's mental health services, have already identified families that they feel from the children they're seeing that actually there's benefits for them to be referred in, and understands the wider issues that are happening with them. It's not going to be a one-way flow, as we've described. It will be a multi-flow information that will be shared and developments, and it's definitely not a tick box exercise where we're making sure that the measures that we identify have an impact for families and are felt. We will keep looking and reflecting on through the contact with Sian for post the MAP meetings with those families, to ascertain whether there are further opportunities and further developments that we need to incorporate and bring back to the MAP meeting to develop it. Next slide, please. So just finally, to touch on the next steps of the pilot. So I've said about the information sharing agreements. We've got them in place now. Our go live meeting is in June, and we've done that because, working back the timeline, we need to ensure that there's sufficient time for our referrals to to be able to land, get the consent from the families, that information to be shared with Sian, and Sian have a period of time to link up with the families and importantly identify what they want to achieve from the outcome of the MAC, or what they want to bring to the conversation. And then our partners as well, we're also recognising that it's a lot of meetings that our partners are being asked to come to, you know, with all the different national drivers. So it's a lot of time that's been taken up from partners. So we want to make sure that it's got a real positive outcome and benefit for all our partners. I've touched on the review and learn, and then that evidence building, really sort of looking at the data, looking at the pilot outcomes, and adapt how we can scale it up for the future, and the adoption as well. I saw one of the questions come in the chat in terms of the length of this pilot. The pilot at the moment is due to run until December. Within the seed funding, we are looking at opportunities of how we can use the slippage within that funding to actually enhance it, whether we take it for longer and do a further evaluation, or whether there's other opportunities in terms of the gaps and things that we've identified within the community. But I'll leave it there and move on to our colleagues from our Sefton team. So Sharon and Jackie, thank you.
Thank you. Yeah. Hi everyone. I'm Jackie Finley. So I currently head up the transformation team in children's, and I'm here with my colleague Sharon. Sharon's going to talk us through more about the role of the voluntary sector, and I'm going to give more of a high level view. It was really interesting to hear Liz at the start talk about families first, because that's what the area I've been leading on for kind of the last 12 months or so. And I think what we seen very early on was that there was a huge alignment, and so there was a real strong opportunity, and that's where the drive came, I think, for jumping into that expression of interest offer that was there. Next slide, please. So we've seen that there was an opportunity to apply for some seed funding, and actually aligning it with the work I was doing around Families First and the work we were doing with the partnership around how we look at whole system change. It just seemed too good an opportunity to miss, really. We knew that there was already work going on in Sefton and in Liverpool around respiratory care, and we knew the voluntary sector were already well engaged and plugged into that. So it seemed an obvious and quite an easy choice, really, to align the two. So the scope of the MDT is to really think about how we can personalise family support, focusing on children who are open to social care with complex needs, or poorly controlled respiratory conditions. In reality, the respiratory element has really come to the fore throughout the planning stage, and really where we can, thinking how we align this to the work we're doing on Families First, with family hubs, and more latterly with the SEND reforms and Best Start in Life. So what we aim to do was have a fully operational MDT focused around the Bootle area, which for us fortunately aligned with some of the work that Right to Succeed have been doing in that area for kind of the past 18 months, 2 years. So it just seemed to make sense to align the two pieces of work, and the idea being that we would look to engage 50 families over a period of time, and really develop a scalable model. From the outset, even at the kind of writing of the bid stage, we had all key partners around the table, and we knew that schools, we already deliver a kind of team around the school approach in Sefton, so we knew that schools would be key to this, as would our colleagues from Right to Succeed, but the wider voluntary sector, obviously with Sharon coordinating some of that support, ourselves as part of Children's Services, and our health colleagues through the primary care networks, Nursey Care and Older Hay. Thank you. Next slide, please. So, as I said, we were really keen in children's services to do what we could to align with those neighbourhood health footprints. Previously, we've operated on 3 localities, North, South and Central. And this gave us a real strong opportunity as we were redesigning services internally to make that link with neighbourhood health and very much shift ourselves to a place of alignment with those health neighbourhoods. So in Sefton, we've got 2 PCNs and 8 neighbourhoods, 4 in the south and 4 in the north. And for the purposes of the pilot, we're really just focusing on that Bootle neighbourhood. Okay, thank you. Next slide. So what we identified was a whole host of expected benefits and outcomes, and that were probably at too early a stage to realise. But what we're hoping for is that the earlier we can spot those health and family support needs and put some, after identifying them, really begin to think about how we can put some support in at the earliest opportunity. We're looking at how health, early health, social care, SEND, education and the voluntary sector, how us all working collectively as one means families avoiding kind of repeating their story multiple times and potentially being given conflicting advice, and the development of a kind of MDT case discussion will hopefully improve workflows, reduce duplication and streamline navigation for families. And in line with what the kind of the health MDTs are looking to do, the neighbourhood health approach is that reduced pressure on hospitals and GP services. And so through the model, we're looking at community-based respiratory clinics where we can provide asthma reviews, testing, and really hopefully reducing that reliance on GP and outpatient appointments. We're looking at developing and working with families through kind of more informal scenarios to include kind of that better inhaler techniques and thinking through those clinics, how we get personalised asthma plans and medication optimisation through those forms. In terms of schools, we started at the beginning to really think about how we could identify the children best, and we had very grand ideas about triangulating data, which didn't actually materialise, possibly due to data sharing arrangements. But what we knew was that if we could identify the children via the school route, that we could triangulate in that sense. So where we're looking for improved attendance, managing uncontrolled asthma better for those children, and really thinking about parental anxiety and environmental triggers through that too. In terms of stronger family engagement, Sharon will go on to talk about how we're really looking to develop that community-based parental engagement through coffee mornings and build that parental confidence, whilst also addressing any potential environmental risk factors. Also keen to really think about tackling inequalities. Built for us is one of our most deprived areas. So thinking about how family hubs, best starting life initiatives, and using trusted local spaces where families are already going to increase engagement for families at the earliest opportunity, but for those who may traditionally avoid more clinical settings. We're looking that we can improve the quality of life for children and families through having more stable asthma control and that reduced crisis episodes, and providing through the MDT more holistic kind of relational support at the families level and where and when they need it. And very much thinking about, as has already been mentioned, the whole plethora of reforms that we've got. How do we get to that system level benefits where we can look at a scalable model that could work across Sefton with that shared governance and thinking, you know, how this aligns with the work that Right to Succeed are doing in the area, but also how it aligns with the pilot that Children's Services have got going on in the same area around family health as well. And whilst at the moment those 2 initiatives have been parallel planned, it's very soon going to come to a point where they align into one stronger MDT approach. Next slide, please. So I won't need to go into this. I think it's been covered by the previous speakers, but it just it'll be in the park, and you can just see how the two initiatives really align, and why that matters. And then I think my final slide, please, is just highlighting what the delivery model will be. So we have been delayed. We were due to have had our first MDT, but we'll be delayed due to some data sharing and DPAI agreements. However, we are hoping to do it to get started in the next couple of weeks. But this will be the delivery model in terms of we'll have that single access point via referral forms coming in from schools that will have consent already. Then the PCM will do some of that initial screening and identifying of needs, at which point we will come to that multi-agency discussion and triage to determine who's the best person to support the family and what co-delivered support we can put in place. At which point we'll develop a family plan and decide who's the key contact for that family and how we'll provide that ongoing monitoring support and review. Obviously, at any point in the process, if escalations are required, that's there and very clear in the process. And alongside that is that community capacity building that I've mentioned, but Sharon will talk about more. And then obviously then going on to closure. I'm going to hand over to Sharon, who's going to tell us a bit more about the voluntary sector involvement.
Thanks, Jackie. Hi, everybody. So I'm Sharon Cottrell, Strategic Lead for Children and Families at Sefton CBS, and I've worked with Jackie both on this piece of work, but also on the Family First Partnership and also Right to Succeed. So the voluntary sector in Sefton very much linked into all of these pieces of work. The voluntary sector agency that's leading on this piece of work for the sector is Parenting 2000. They're a well-established charity in Sefton, and they are already providing early help that's commissioned in Sefton. They provide mental health support for children and people. They provide youth clubs, and they already have a person who's providing respiratory support to families. So there was already some work going on within that charity, which was why they were the person that we identified that charity to do this piece of work. The overview for the programme was the idea, as Jackie said, to improve respiratory health and reduce school absences linked to asthma and breathing difficulties. And this is taking place in two Bootle primary schools, Bedford Primary School and Thomas Gray. The programme is going to be delivered by Parenting 2000 in those school settings. As Jackie mentioned, parents are going to have the opportunity initially to attend coffee mornings, and Sarah, who's going to be delivering some of this work in the first meetings, which will be taking place soon, to consult with those parents about what they want, what they need, how they'd like it to look. She has got some plans about what the delivery will be, but she will definitely be taking into consideration what the parents tell her, parents and carers, at those initial conversations. And as I said before, she's going to be working with partners from Team Round School, Primary Care Network, and Asthma Clinic to ensure that all support is linked and integrated. Next slide, please. So I won't read these out. You can read these slides, but we were looking to improve the respiratory health, reduce school absences, equip parents with knowledge and tools. So the plan is to have peer support champions that will be parent or carers. So once this piece of work comes to an end from the funding point of view, but there will be a legacy because there will be parent champions who can continue this work with health colleagues. There'll also be education materials to support parents in supporting each other. There'll also be the opportunity to address environmental factors. So respiratory health can be affected by damp in properties, cold homes. So we are linked in, there are pathways with our colleagues in housing and also other voluntary sector organisations and health organisations who can support with people in their homes to make them better places for young people to be able to be healthy and breathe healthily. They're looking to strengthen schools because schools can attain an asthma-friendly accreditation. That's already started in those 2 schools, and they're already learning from that, things that they hadn't thought of previously. So there's already good information coming out from them starting on that accreditation journey. And as I mentioned, the peer-to-peer parent support, which is something that Sarah's going to develop. Next slide, please. So there's going to be workshops and education for parents. There's going to be reducing environmental triggers, joint workshops with partners such as Energy Project, Full Screen Doctor and Groundwork and Fuel Poverty Support with Energy Advice partners, and also looking at things like damp and mould advice, using safe non-toxic methods, making sure that the houses that the children and families live in have got good ventilation, and that's something that families wouldn't necessarily know who to go to, this sort of thing, but Sarah has already been doing work around this, so she already has trusted relationships with these organisations that she'll be able to use in this piece of work. Next slide, please. So also, in 2000, they'll be working in partnership with Living Well Sefton, Active Sefton and social prescribers. The Living Well Sefton social prescribers are part of Sefton CVS. So again, already established relationships between all of those offers and Parenting 2000 to be able to support the children and young people to be able to improve their health. Also encouraging them to be able to get outside and enjoy a lot of the natural environments that we've got in Sefton. Again, making sure that children and families are aware of what's available. Sometimes when we're working with families, people aren't always aware of what's on their doorstep. Also healthy eating and well-being, because good nutrition, good sleep, all increases health outcomes for children and young people. And also linking in with Smoke-Free Sefton, because smoking and vaping can contribute to respiratory health for children and young people. Next slide, please. So we've already mentioned that there's going to be parent peer mentors, and they're going to be supported initially through Parenting 2000, but also with a sort of exit strategy for them to be able to continue and develop and share good practice moving forward. And also, as I mentioned earlier, the accreditation for schools and training for staff with awareness materials for families, again, that will still be there. We were talking at the meeting, we've got a task and finish group for all the agencies that are going to be supporting Parenting 2000, and we were talking about making sure that in the education materials we've got live links, so that as that piece of work comes to an end from a funding point of view, that things are live. It's not something that goes out of date very quickly, so that parents have still got access to up-to-date and meaningful information. Next slide, please. So this is just the outcomes, and we've been talking about what to do, so most of them have already been mentioned, but that just gives you a clear view of what we're aiming to achieve from this piece of work. Next slide, please. Okay, I think that's it. If anybody's got any questions for Jackie and I, we will answer them as far as we can, and if there's anything we can't answer, we'll take them away and come back to you. Thanks.
Yeah, thanks, Sharon. I think we'll probably use this time to look at questions for both, well, actually all 3 sort of presenters, really. I've noted a few questions as we've gone along, and I've written them down, but is there any, I'm going to ask a question of Liz, but if there's any other questions that you want to add, could you actually use the next few minutes or so to put those in the chat? Liz, could I come to you? And I know you've obviously been involved in both the initial concept of this. You were obviously tasked by the ICB to look at neighbourhood working. Putting you on the spot a little bit, Liz, as I have a habit of doing, what do you think has been the biggest challenge in these pilots? And what do you think have been maybe the biggest benefit or some of the biggest benefits?
Yeah, I think the challenge is is that these aren't fully funded processes at the moment. And what we're asking, and I think I alluded it to my presentation, it's that we know that this will create savings eventually, in that it will improve outcomes, but it will create savings. But actually we're double running. And how do you prioritise early intervention prevention when, particularly for the NHS, there is such a lot of heat on adult acute wait times, so A&E waits around adult recovery times, etc. I take absolute hope from the fact that there are children's frameworks being published, that we're about to have a children's modern service framework published as well, one of 6 modern service frameworks. And so there is a focus on children and young people, but I think it's about everybody on this call and everybody who is around supporting children, young people and their families, absolutely pushing forward with the expectation that children will be a population cohort that we cover, and that we continue to move forward with that. I think the systematic approach to this is work that we've got to do over the next couple of years about how does this become the way we do things around here, rather than a pilot here and a pilot there and a pilot somewhere else, and how do we get that sustained funding. And in that, I think there's something about, particularly as the ICB settles into its strategic commissioning framework, how do we support conversations about third sector delivery as being trusted partners and not being kind of a bit of slippage funding here and a bit of slippage funding there? And how do we get that absolutely in the baseline around delivering a different offer to families that meets their needs?
Brilliant. Thanks, Liz. There was a question in the chat from John that I'd like to address to you, Bev, if possible. And John's saying quite rightly that the vulnerable sector is all shapes, sizes, areas. I think John's question is really, what do you then see? What type of VCS groups do you think are most appropriate around neighbourhood working? I've said that we've seen all sizes, but what have you seen? And in particular, Bev, because I know you really well, your experiences in Family Toolbox and other things about the nature of those groups that have got involved.
Yeah, I think for me that the value of our sector is that we all come in all different shapes and sizes, and we all offer something different. So when you're talking about children and young people, you're talking 0 to 18 up to 25 with SEND, and we need those organisations to do a wealth of different things. So not one size fits all. Families need different things, want different things, and so I do believe, I mean, from my experience with work we're doing, like you say, with Family Toolbox, with Branch, but also in Cheshire West with the Thriving Families CERT programme, we are different organisations involved. We are all different sides, and we have those wider organisations. So to me, whether you're a very small organisation with just volunteer-led and a couple of organisations, or you're a bigger organisation like ours that have got quite a lot of services and family staff and volunteers, it's about the important thing is what the families want, and the role with neighbourhoods is to make sure we know what is out there in the community and across all our organisations. So it's anybody who's sort of doing any of the work on the neighbourhoods, it's not just thinking about what they can do, it's about who else is out there and making sure that our sector knows. So it's going through so it's making sure the CVSs and the likes of Cheshire West Voluntary Action, the equivalent, are making sure that voluntary sector organisations across the region know what's going on around neighbourhoods and what opportunities there might be coming up.
Kerry's raised a really important one, Bev, and because you're on it, I'll stay with you for a minute and see if any of the others want to add. Is that obviously big nutshell about referrals coming to the vulnerable sector with no monetary recognition or support? I don't know if you have a view on that in the current climate.
Yeah, definitely. I mean, this is a discussion that Heather and I have had as well, because our part in this neighbourhoods for Cheshire West is we're not getting any delivery money, but we are working in that area with other funding. One of the earlier slides that Liz showed about the number of referrals that were going into the sector, that is a concern for the sector because we can't cope with the demand if we haven't got the funding to match it. So it's really important that as this model takes off, that the NHS is investing in our sector. Otherwise, it's not going to work. Otherwise, you're going to identify, even with the pilot that we're doing, and Heather, like I say, Heather and I have spoken about this, we might well identify a need. I think we'll identify gaps. I think we'll identify gaps for families, but we'll also identify services that could support them, but they can't take the referrals because they're at capacity and we're not funding them to do it.
Brilliant. I mean, the one that I'll come to you, Jackie. Yeah, definitely. But the one that Liz highlighted in Solihull, the GP Rizwan, was sharing how much funding, I don't think he put it in the slides, actually went to the sector as a result of that model. And I think that was clearly a very developed model where they were actually funded both to capacity build them to set up, and also then funded actually for what the referrals came. So yeah, 1,000 referrals is a big, amount of extra if there's no money. Jackie, you wanted to make a comment?
Yeah, it was just building on what Liz had said and thinking, that we do need to find a way to fund, but I think it's almost bigger, and it's a whole system thing as to how do we do that, from a children's services, from a health perspective, from an education perspective. There's that many reforms about, whether that be SEND, whether it be Best Start on Life, family hubs, families first, neighbourhood health, they're all saying the same thing. They're all saying we need to intervene early, we need to do it on a neighbourhood basis, or maybe we need to look at pool budgets and do things completely differently. I know that's not a short-term answer, and it's far more complicated than it sounds, but we have to have that ambition of doing things differently.
Totally. Heather?
Yeah, just to build on what colleagues have mentioned already about this, the way we've set out with the Cheshire West model is that we're fully anticipating that the evaluation of this pilot will help us to identify the gaps in our system working, and actually where we need to kind of highlight and implement additional services. And I'm fully aware that that will be within the voluntary sector and within our community. This will give us the stronger kind of needs assessment and evidence to say, actually, we can impact and support families by having additional provision in X, Y, and Z within our system. And just to mention that it feels like our government are recognising that there needs to be funding attached to the neighbourhood framework, and we have identified additional funding that's potentially coming down into the NHS as a system. I think it's something like 4.2 million potentially coming, that will come to the ICB and then be able to be supported on a long-term plan. So I'm sure that's part of the thinking, and from our perspective, we're doing that planning.
Heather, could I also ask you a question about information sharing? Because you said obviously it'd been a challenge, and I was at the neighbourhood event beyond where it was discussed. You hinted that you'd done some work on it. Could you just give a bit more detail and say how you found a workaround?
Yeah, sure. So within the team that we're working together, we've done an in-depth DPIA. So we've had that supported.
Could you do an acronym speak, Heather? Sorry. DPIA. It's all right.
Yeah. Oh, now you put me on the spot.
Isn't it a data processing information assessment or something like that?
Yes, I think that's close enough. So we've had that approved, but what we've done is outlined the whole process that we're taking and the explicit consent that we're requesting. So the barrier is for voluntary sector to be a part of the MAP meeting and have that information. The rest of sort of health and the rest of the partners involved is not the barrier, it's the voluntary sector. But through that explicit consent, and we've developed a form, like I said before, we've made it a digital form, so we've tried to reduce as many of the barriers as we can, and supporting information as well for families to understand what they're consenting to has been really a valuable part, and some of the time that we've taken to kind of get our ducks in a row before we kind of go out there. So the explicit consent form has been supported to help enable us to be able to progress with the voluntary sector at the forefront, getting that information and the detail, and then contacting the family. Importantly, that's Sian's role then to further have that contact with the family. But yeah, we've managed to do a workaround with that.
Brilliant. Thanks, Heather. Liz, can I come back to you with Kerry's question about an end of pilot report?
Yes.
Sefton may do a report because obviously they're involved in a national pilot as well. But in terms of the beyond pilots, what kind of evaluation report, lessons learned is going to be sort of produced so that, as Kerry says, you can help other neighbourhood models learn from that best practice?
Yeah, absolutely. So we've already held one neighbourhood event that I talked about at the Florrie, which was about sharing good practice and getting people together to share where they're up to, what their challenges were. And actually, I think people found that really useful. We are undertaking regular meetings with all place areas in relation to the key lines of inquiry for the seed funding and for the areas that didn't get the funding. And we will be pulling that together as we move forward into an evaluation as to what works well. What are the key things that we need to lift and learn from, and then what would we recommend as we move forward? And hopefully over the next year, more and more MDTs will develop. So we need to keep a really weathered eye on making sure we evaluate and share that learning. So that will be happening.
Brilliant. Kerry, you've got a couple of more questions that I think are probably a bit long to answer in the sort of 5-10 minutes we've got. Liz, obviously we've highlighted Cheshire West and Sefton, and in some ways those were because I knew them quite well and I knew they had a strong voluntary sector engagement. Cheshire East have proposed doing something, have they not?
Yes, they have, and they're on their way now. I think there may be a colleague, I think Bethan Rimmer might be on, who is one of our colleagues who is supporting us with that. But they have a GP surgery over in Cheshire East that is looking at children with multiple needs and multiple challenges, and with a focus on respiratory. So they're working really closely with their local hospital to get those MDTs set up, but are already looking at extended appointments for children with respiratory issues. So lots going on in all of our places. I think this is just an absolute high level on a couple of places who we've got going, but absolutely all of our places are working forward. And if you look at the pack when I send it around, there'll be a little bit more information about the other areas.
I'm not sure if there are any colleagues in Warrington, but I've actually got a meeting organised with Sharon, who's the Director of Children's Services in Warrington, to discuss a Warrington programme. So yeah, I think we are going to get to a stage where we have 9 things going on, is the best way I could describe it, which is good. Yeah. Sharon, you have your hand to share something.
Yeah, it was just in answer to Kerry Maud put in the chat, what do we see as a crucial aspect in building trust? In the group that we're meeting weekly, and both of the primary schools are represented on that group, and they feel that they've already got a really strong trusted relationship with the families that they're going to be referring into this, and also that there's already a sort of a good trusted relationship with the voluntary sector, and that they think that that would be, you know, crucial for families to not feel under pressure and to perhaps, you know, feel more comfortable talking about things than in settings that they might feel that they're under more pressure. So that's kind of what our thinking at the moment in the work that we're going to be doing.
Brilliant. Thank you. Okay, I have captured what I think was a couple of key sort of themes as we've gone along. I'm sure there's lots more than these, but these were the 6 things that sort of really jumped to me as I read people's presentation. The first has been said again, there's an increasing importance of neighbourhood working, and taking Liz's point and others, that this isn't just being seen in health. We're seeing the emergence of Youth Futures hubs, Families First programmes, family hubs. So it is going across a whole range of agendas. The importance of consistency and equity in the voluntary sector, that they're an equal and embedded part of the voluntary sector, not a peripheral part. I love the slide that said it's about ensuring families are at the centre. For me, I'm obviously very much focused on young people. I want to see young people at the centre of things and able to influence and shape it. learning together and the importance of continual improvement and looking at how things could do better, using data and evidence of need to influence the focus, but also recognising that we need to help join up those monitoring systems, that perhaps for the voluntary sector, that they can't quite access all of them, and so helping them, and the importance of capacity building the sector to do more. I think we have a fantastic voluntary sector across the 9 areas, but I think sometimes we need to give them that little bit of help just to develop further, particularly if we want to help those small to medium size groups in the sector. So I'm seeing quite a few more sort of comments coming in. Liz, yeah. Not over promising. Yeah, get that one. Unpicking it further. Any other comments that anybody sort of wants to make? Any last minute statements? Liz, is there anything you want to add in terms of next steps?
I think it's early days, and I think we will learn and grow as we go. And I think it's about continuing that communication, making sure we've made the links where possible, and being really mindful this is how our families have indicated that they would benefit from support. It's not going to be easy, and I think as with all things, there's such a lot of work to do that I think we will always get to a point where somebody goes, but you haven't thought about that and you haven't thought about this. But actually the wealth of the intelligence and experience of all of us together, if we work collectively and compassionately, we will get there, and it will be better for our children, our young people and our families, and it will improve their outcomes and their access to opportunity. So I think it's the right direction of travel, but it won't be done in this year. It'll be done over the coming years as we move forward.
Sure. Yeah, brilliant. Thanks, Liz. I'm going to put my address in the chat. Obviously, a number of people on the call are already aware of the Children and Young People's Voluntary Sector Network that both sort of Sharon and Bev and a few other people, Kev Bradburn from Youth Fed on the call, are involved in. But if you wanted to have a conversation about the network, feeding into it, or finding out a bit more about what it does, then please drop me an email. Thank you for Lorna and my other VSNW colleagues for their help running this smoothly and doing all the things that I'm not very good at, which is quite a few. So if no one else has got anything else to say, I will finish there and take great pleasure in finishing a couple of minutes early. So thank you to my presenters for keeping it nice and short and snappy, and I wish you all the best for the day.